Good afternoon and welcome. It is my pleasure and privilege to invite you to this lecture. It's actually not a lecture. It's just my words about the past 30 years, which is my interest in ophthalmology, and 20 years, which is my academic career. Many years ago, I came across this phrase of Leonardo, how something so small can contain the wonders of the universe. And actually all my life I was fascinated how true it is. But let's the journey begin. Once upon a time, in 1988, I had a privilege to meet ophthalmology. That was my summer studentship. And during that time, Wonder One happened to me. So during that time, I understood that actually cataract means a piece of a waterfall. And a cataract actually is a disease which causes blindness all over the world. Don't have too much faith in what I have seen during that time, because actually during that time, couching, which you see here, and this is Robert of Salerno, who is actually performing couching with a goose quilt, was something which was very similar to what I was exposed to. So this is a picture of the theater during that time. As you can see, it is very different than the contemporary theater. And I was supposed to be helper in this theater. And one day, when there were not enough staff, one of the professors said, okay, you wash yourself for the first time in my life, and actually you are going to hold the cornea. But you have to be very careful because I'm going to use this freezing device to take the lens out. That was after already they were using hyaluronidase in order to make the zonules weak. I cannot explain how stressful that was for me, because all the time I was holding it, I was almost trembling. I was thinking that this cornea is going to fall over this freezing device and this is going to be a disaster. Later on, I was exposed to other different techniques, like extracapsular cataract extraction. This looks pretty much like a delivery, of course, and still I was very interested in ophthalmology. During this time, I was really more like a handholder and more like a helper. But I also managed to encouple some knowledge. And I also managed to understand that there are advances in ophthalmology. For example, somebody was telling me about Harold Ridley and about the option that instead of using aphakic glasses, because this is what I saw at the clinic, we can implant intraocular lens. Later on, I actually was introduced to an idea that somebody was in a dentistry cabinet and they realized that using ultrasound to clean the dental problems may be used into the eye. At this stage, phacoemulsification was like a mystery for me. But Kelman actually managed to do it. And in some countries, when we were still doing intracapsular cataract extraction, they were doing phacoemulsification. In 1989, I was invited to do some translation at the Orbis International Plane, which at that stage was visiting Bulgaria. And this is my first ever assistance to a phacoemulsification. The surgery was performed by Stephen Slade from United States, and they invited me to just drop a few drops on the cornea as an assistant. That was for me the most amazing experience. And actually, that was for me the first exposure to phacoemulsification. At the same time, one of our professors was in Israel, and he brought to us the methodology which is called mini-nuke technique, which was invented by Michael Blumenthal. And I must say that this technique I'm still using sometimes today, and it is still working. And I've done more than 3,000 of those operations myself. And although it's not phacoemulsification, it's not comparable, at the stage it was extremely good way for transition from traditional cataract to a new technology. Today, of course, phacoemulsification is everyday surgery in our theater. And today we are more focused on what kind of lens to choose, what kind of technique to select when we have complicated cases like shown on those pictures. And I do believe that the future, maybe for the next 10, 20 years, the most important thing will be to find a lens that absolutely replaces our natural lens with accommodation and ability to focus at different distances. During this time, I came across various different technology. One interesting thing was this aqualaser idea that instead of using ultrasound, we just use jet of water. Of course, not everything that came onto the market was very successful. Today we are looking for femtosecond, for example, and although femtosecond looks very interesting as a technology, although there are lots of debates about it, my personal opinion, of course this is my personal opinion, is that this kind of technology maybe is not going to have the same position like the phacoemulsification has, and maybe we are going to use slightly different way and preserve the anterior capsule as well, and maybe use something to fill the space between the capsules and have something which is adjustable, maybe with lasers, maybe with contemporary other technologies. But in conclusion, for wonder number one, I can say that all ophthalmologists love cataract, like shown here. And this is because we appear somewhere here. The patient has no vision or very low vision or disturbance in their vision. And after that, we ended up usually when the patient is already very, very satisfied. So what about wonder number two? It happened not later, it happened in 1989, and that is related to my meeting with the eminent Russian professor Mikhail Fyodorov. This Russian professor in 1974 invented radiokeratotomy in a way which is slightly different than the subtle way. Actually, I have the privilege that Fyodorov told me his original story about radiokeratotomy. And the story is the following. There was a young guy who fell from his bicycle, and he had very severe corneal injury. And because the injury was multiple, like the cornea had different places where it had some radial incisions, Fyodorov decided, because they were not full thickness, Fyodorov decided to continue with those incisions and just see the optical result. This guy was about 3.5 diopters short-sighted. At the end of the day, with those symmetric incisions, his visual acuity was 20/20 or 100% without any correction. The difference here that Fyodorov made in comparison to the classic technique was that he started the incisions from center to the periphery, and this is actually the classic Fyodorov technique. So that was my first exposure to refractive surgery, and later on, of course, I had the option to visit Fyodorov's clinic in Moscow and the one that was here very close to my place in Albana. Of course, radiokeratotomy had quite a lot of complications. And here are shown some of the complications, especially of the technique which starts from the periphery to the center. And therefore, this technique was quite famous for a short period of time. The thing that really impressed me when I was at the Fyodorov Institute in Moscow was this thing that in Russian is called rumashka, and basically this is like a carousel. Every surgeon is doing a small step of the surgery. The interesting thing was that he tried for the first time to make an industrial production of cataract surgery, but at the same time this thing was unsuccessful, because if somebody made a mistake, then everything had to stop, and that was very complicated for the patients. For a short period of time this thing worked, but fortunately today we are more into the personalized medicine. During that time I had an interesting meeting as well with my mentor at the stage, Professor Mitov, and he was a very pushy guy. So here you see me, I'm trying to have a coffee, and he was pushing me to go and take corneas, because at this stage we did not have an eye bank. We just were using fresh corneal tissue. And this is one of the first grafts that was made with the cornea that I took myself from a cadaver that was in the pathology department. Of course, not always we had rough relationships, sometimes we were having fun as well. A little bit later, I also had the privilege to meet in person John Marshall. And John Marshall is the guy that invented excimer laser into the corneal surgery. And this laser we are still using, of course, in much more advanced stage, because we know all the disadvantages that this laser was providing us at the first steps. But probably the most important meeting with refractive surgery in my life was with Charles McGee. I met Charles in Dundee, and he was doing lots of laser surgeries at this stage, lots of excimer laser, including patients with short-sightedness from 1 to 10 diopters. Of course, Charles being Charles, always was looking for complications, always was looking for advancement, and he was more focused on downsides than on the progress, and that actually led him to extraordinary progress. At this stage we wrote a book together, which is the first full-color book about the cornea, and later on I actually traveled to Auckland and spent there 3 years, and during those 3 years I learned really how to make corneal grafts. I learned phacoemulsification in details and lots more. But very importantly, I learned how to manage complications, because managing complications is something really important in the career of an ophthalmologist. This is again a complication. This is not Charles's complication, but Charles discovered it. This is a buttonhole, and as you can see, utilizing confocal microscopy, we can not only observe what really is going on and how the epithelium is going under the flap because there is a buttonhole, but also we can make a theories, like seen here. We actually made the theory how the epithelium is ingrowing and how this can be treated on a long run. I finished my stay in Auckland with finishing my PhD thesis, also with some 24 publications, but very importantly, I came back to Bulgaria with very advanced clinical skills because of the team there and mainly because of my mentor, Charles McGee. At this stage, I understood that the refractive correction is a matter of lots of techniques. That includes the implants, laser surgery, later on femtosecond surgery, corneal grafting, and of course incisional surgery. My personal belief at the moment is that implants are going to be most important part of the refractive correction in the future, at least of the surgical refractive correction. And I do believe in artificial and semi-artificial cornea, and I do believe that some implants of artificial cornea are going to replace lots of optical properties. What is wonder number 3 for me? Well, obviously this is contact lenses. In 1991, I was formally introduced to contact lenses. That was a course that I did with Associate Professor Tsaneva in Sofia. And during that time, I understood a lot about optics. The idea about contact lenses belongs to Leonardo da Vinci, and later on, Adolf Fick really made those lenses. At the stage, those lenses were sclero and they were hard. And as you can see, people were behaving towards them like they're a piece of jewelry. A little bit later on, Otto Wichterle in Czech Republic managed to invent the first soft lenses. I had the privilege to meet his son, and his son was around 12 when his father was doing the experiments in their garage. And his father was chewing the lens, putting the lens on the floor, stepping on the lens in order to test the contact lens materials. From contemporary perspective, this sounds a little bit cruel because today we have lots of gadgets to test the modality of the lens, to test the modules, to test the elasticity, to test the lubricity, to test the friction. But at this stage, that was an empiric period of contact lenses. So when we are talking about contact lenses, I should talk a little bit about eye health. For me, eye health is just treating that our patients are seeing well, their eyes are looking good without any signs of ocular disease, and also they have no symptoms, so basically they also feel good. So why contact lenses? Well, my 20 years of experience shows that contact lenses are safe. Today they are the best tailor-made refractive solution and correction, and also they have natural positions, so we are somehow overcoming the vertex distance. The safety of the contact lenses is within the studies that had been done related to contact lens complications, and we all know that the serious contact lens complications, if patient is compliant, are 1 in 10,000. And considering the surgical complications, which are mean of 2.5%, this is absolutely nothing. So the main goal today of contact lens practice will be to have more and more compliant patients. When it comes to tailor-made solutions, we need to meet very many needs. And this is what we can do with contact lenses. This is a cheap experiment. Patient can have them in the real life, which is not for glasses, for surgery. It's absolutely impossible. And we can follow them up dynamically and tailor them dynamically. So in fact, contact lenses are providing us with unlimited options. Also, they have natural position. We can manipulate the optical zone of a contact lens, which provides us with very good visual field. And also, they have optimized position in regarding to the nodal point. Quality of life is always something which is on the table, but basically not many people realize that quality of life is directly related to quality of vision. And when it comes to quality of vision, I should say that contact lenses are a delicate balance between lots of property like functionality, compliance, easy to use, also aesthetics, which is something for teenagers, for example, it is very important, social factors, and of course today contact lenses are safe and not very costly as well. What we should remember as contact lens practitioners, however, is that we should have very different approach to different age groups and even to different gender groups, because it is very, very different to approach people of various different backgrounds and various different age groups and of course gender groups. But still, contact lens is the best option for many patients of mine. So contact lenses are optical correction, but is this all? Basically not, and I'm very happy that in my life I had those unique cases and I was able to apply the rules of personalized medicine in order to help those people. This girl, for example, is a girl with oculocutaneous albinism, and she was not able to look straight ahead just because she was suffering extraordinary photophobia. She had enormous nystagmus, pendular horizontal nystagmus, and her visual acuity was 0.1 with significant refractive error of about -4. What we did for her, we did custom-made lens, which was with artificial iris. The iris was painted on the lens, red pupil, and of course the optical power of the lens was according to her refraction. And finally we ended up with visual acuity of 0.3, and this girl was extremely happy. What I should say at this stage is when somebody of my residents or young people have something in mind and they really implement it into the practice and it really works, they should patent it. That was one of my greatest mistakes. I did several things, but I never submitted the patent. For example, X-chrome lenses are very similar to what we did at that stage about 20 years ago. I'm doing lots of therapeutic lenses as well, and this is not all about vision. This is about comfort as well. At the beginning I was very cautious about using therapeutic lenses because of course those lenses are staying during sleep and we're afraid of complications, but with time I realized that there are many cases where therapeutic lenses are providing patients with comfort, and also they are facilitating, like in this case, the amniotic membrane to stay longer on the ocular surface and amniotic membrane over the corneal graft to stay longer on the ocular surface. And over the years, of course, I needed to publish few books, and those are some of those. So what about my next wonder? This is wonder number 4, and that happened in 1997, so we are going close to the end of the century, and that was something which I saw during my specialization in Moorfields Eye Hospital. At this stage in Bulgaria we did not talk about dry eye. Dry eye was just not existent, and there in Moorfields they were having dry eye clinic. So that was very interesting for me to realize that the layer of the 3 layer of the tear film, which is the mucin layer, the aqueous layer and the lipid layer, is actually not that simple. It's not a sandwich. It is something more complicated. It includes mucins, and those mucins are evenly distributed all over the water layer. And that was an interesting concept that actually taught me a lot, because dry eye was something which is paradoxical by itself. Most of the patients with dry eye actually had watery eye. So for 20 years I was trying to understand dry eye, and those are some of the lectures and seminars that I was given. But during those seminars it was more like a teaching expertise for myself, because every time after those lectures or seminars, from the questions, from the discussions, I learned something new and something more. And if I need to summarize, dry eye is actually the disease, and by contemporary definition dry eye is actually a disease, is the disease that trained me a lot. It put together my doctor's sense the most, because I learned during this process that when you are examining eyes, you need to use not only your eyes, but you need to use your ears as well. I started to pay attention to the finest detail, and my eagerness for technology developed enormously, because dry eye is developing, and the technology that we are implementing into the dry eye diagnosis is more and more today. And of course, the interesting thing was that I understood that even the oldest tests, if they are significant, they can help you in the real clinical practice. And good example for this is the Schirmer test. So the importance of the symptoms in dry eye are very, very crucial. And For example, patient comes to us and they have all those symptoms, and we look at the eye and there are no signs. Using confocal microscopy, however, we were able to prove that if patient is symptomatic, even there is no clinical signs, sometimes there are signs. Just we do not see them. Just contemporary everyday clinical technology is not allowing us to see something which stays behind the symptoms. Like in this case of dry eye, we have inflammatory cells. It is important to know that when we have a combination between signs and symptoms, like for example with all those symptoms, we are having red eye as well, and then we try to look at the microstructural level, we see all those signs which are dendritic cells. So basically when we have significant inflammation with redness and clinically inflamed eyes, we are seeing more secure signs at microstructural level. So when it comes to the ocular surgery, of course, it is very close subject to my heart. I always ask myself, we are doing surgery in order to help the patient, but is there any surgical procedure that is not causing dry eye? I'm very happy to provide some grant for somebody who finds a surgical procedure not causing dry eye, because anything that we do, even when we apply a simple drop of anesthetic just because a diagnostic procedure, because we are going to do a diagnostic procedure, in these cases we also are causing dry eye. Laser surgery, no contact lens, but we still keep the eye open for such a long period of time. Of course, we are causing dry eye. And of course, all those other everyday surgeries, including cataract surgery. So this is what we were observing 3 days after phacoemulsification. After my fellowship with Charles McGee, I always was trying to stick to sclerocorneal tunnel, because Charles managed to persuade me that this is better than clear temporal incision in phacoemulsification. And what we can see here is all those changes, and obviously, and this is over the tunnel, obviously if we try to preserve the cornea, it looks much better. But the interesting thing was when we were looking at the conjunctiva, and in those cases you see that regardless are you using two techniques, if you apply artificial drop, the cornea is looking much better. So artificial teardrops help all those patients regardless what kind of surgical technique somebody is using. So basically our surgical technique can be enhanced, and the fact that we are causing some trouble with our intervention can be enhanced with some lubricating eye drops, which is very interesting concept. Very often our patients are having symptoms, and if we are not paying enough attention to those symptoms, we may misdiagnose them. And this is a good example when we have those symptoms and we are not looking for signs, because the signs are not really from the ocular surface. Those signs are coming from the eyelashes. And this is what we can diagnose in this case. This is Demodex, and Demodex is getting more and more interesting. Not because only in the past we were underdiagnosing it, just because today the lids are much more compromised by a variety of different factors, environmental factors, cosmetics, the way of eating, the way of treating our eyes, and of course this very social environment which is around everybody of us. So Demodex is getting more and more diagnosed, not only because we have more modalities for diagnosing it, but also because we have more and more of it. So how we treat Demodex, the interesting thing is that lid hygiene is the big thing that we should use, and there are some basic things like replacement the pillowcase, and of course tea tree oil And I'm very happy that in our laboratory we managed to develop a product that is helping patients with Demodex. When it comes to wonder number 5, I should say that it started in new millennium. And whoever looks at this presentation, they probably will recognize the map of New Zealand. And yes, this happened to me in New Zealand at Auckland University. And when I stepped there, first thing I was introduced to was the confocal technology. This is like an ex vivo confocal microscope. This is extraordinarily good technology that allows us to see in fine details lots about cornea. This is corneal epithelium with a special pit, as you can see here, and those are keratocytes. And actually, if you use red-green glasses, you will see that those keratocytes are three-dimensional. We just false color them in order to see the three-dimensional image. At this stage, I was very interested in ex vivo studies because in my country till 2000 I was not exposed to pathology, and I managed to publish few interesting papers together with my supervisors. And of course, the most important thing was in vivo confocal microscopy. At some stage in the department we had 2 machines because the whole project was supported by Maurice and Phyllis Peikel grant, and I was Maurice and Phyllis Peikel Fellow, Corneal Fellow at the department. But we really needed to find a modality to diagnose corneal structure in vivo. And yes, I had the ability. You see how stressful it was for me. I really look a little bit of unhappy, and I was wondering what is going to happen. But it was a fantastic project. Because at the end of the day, we realized that this is a methodology that allows us to see all cellular corneal layers with various different pathologies. And all those 24 papers came from the fact that those pathologies were readily visible immediately after the clinical examination. So when I was trying to highlight what the confocal microscopy applications are, I came up to these research and clinical applications. And we can use this tool either in research laboratory and in clinical laboratory as well. And those are the applications like in research, descriptor, discriminator, dissector, 3D reconstructor, and 4D reconstructor. And in clinical practice, we can use it to describe pathology, to differentiate pathology, for example, corneal edema from hepatic disease or from some other causes, to diagnose even, to make prognosis, and of course to follow up all those patients over the years. There are some downsides as well, and one of those is the thickness of the sample. Contemporary technology allows us to have a sample of a certain thickness, but at the stage when we were using NIDE ConfoScan 2, we had big problems because we were optical shadowing, we had ghost images, we had lots of artifacts, and I had to do lots of artificial experiments with beads that I put into the jelly in order to try to work out how to rely on this machine in the real life. We did a lot of work on the subbasal nerve plexus, and here you see some of those subbasal nerves, their branching, their beadings, and of course this is one of the papers. This is actually my most cited paper ever, with lots of citations, and that was one of the first papers in the world dedicated to in vivo evaluation of the corneal nerves. We used analysis system just to look for the length of the nerves, and the same system just to look for the thickness of the nerves, and the same system just to count beadings, because we realized that in some pathological situations like in diabetic cornea we have more beadings. One of the very interesting things was that in New Zealand, because of the surrounding islands, they have some interesting dystrophy. This dystrophy that I'm presenting here is fleck dystrophy. It's not interesting because it is very common all over the world. Very often we just ignore it. And for example, this is the Francoise Newton's very specific type of fleck dystrophy. And this is another dystrophy, which is Meda-Dennis. So on the clinical picture, you saw the mother and her two children. Of course, the children at the stage were not applicable for confocal microscopy. And on the other side, you see something which is almost invisible without confocal microscopy. And confocal microscopy actually makes a real diagnosis of a real disease. The most important thing for me was that I needed, when I came back to Bulgaria in 2002, I needed to make the same laboratory with the same quality. It took me about 10 years, but finally we had the HRT3 technology as seen here, and you have a list of already finished PhDs of my students, 6 in total, and there are another 6 that are ongoing and they are going to finish within the next few years. One of the interesting projects during this time was the Mu symbol project. I started the Mu symbol project with Jennifer Craig and Trevor Sherwin back in 2002, of course in New Zealand. And at that stage, Jennifer published the first paper. She was the main author and she was trying to collect those Mu symbols from her own eyes, and she was trying to work out what exactly those Mu symbols are. Actually, Eric Pappas made a very nice joke that Mu symbols are like Paris Hilton and her sister. Everybody knows them, everybody sees them, but everybody ignores them and they do not want to deal with them at all. And this is absolutely true for the Mu symbols. When we already established our laboratory, we started to collect those balls, and in 2017 we managed to set up a study where we were looking for 2 different groups of Mu symbols. One on patients that are just continuously wearing their lenses, absolutely voluntary, and one on patients that wear their lenses because they are therapeutic lenses. And we managed to compare those, and as you can see, the therapeutic lenses are having many more and more interesting in shape clinically Mu symbols, and the other Mu symbols are very small, usually central, and they do not vary in size so much. And this is what we encountered using confocal microscopy, and those gigantic Mu symbols we observe usually in patients that are wearing therapeutic lenses. We looked at the option how those Mu symbols are affecting the epithelium, and of course we managed to publish a paper which is from 2017, and you are very welcome to refer to this paper because I think that this is a very interesting conclusion. Now we are coming to my next wonder, which is wonder number 6, and of course it happened in 2003. In 2003 I came back to Bulgaria. That was a little bit of a rough period because I was away for 3 years. I was keeping in touch with my department. I kept my honorary position here. I was working with them. I was providing some advice. When I was coming back, I was still examining patients, but I was away for quite a long period of time. During my stay in New Zealand, again Charles McGee and his team introduced me to the amniotic membrane. And I understood that this is an ideal matrix, and this helps for anterior ocular surface to restore because it has anti-inflammatory properties, and also it prolongs maturation and growth and adhesion of the cells into the anterior ocular surface. And there are many clinical effects, and those clinical effects I also saw when I was at the Auckland Hospital, and I also saw how beneficial the transplantation of amniotic membrane could be. It took me quite a while to find out where we can have an amniotic membrane from in Bulgaria, And in 2005, I already had the option to register as a user of amniotic membrane into our agency for transplantation. The membrane at the stage was kept in a very big piece, as you see from the picture, in a glycerin, 50% glycerin. And I developed a protocol for extempore dividing this membrane and applying this membrane into eyes. Up to now, we managed to transplant over 2,000 membranes. And we are using various different techniques. Actually, amniotic membrane is our national pride because we managed to disseminate these techniques to different centers, starting with Stara Zagora and after that other centers like in Burgas, in Sofia, and some small centers as well. Currently, the main problem is that amniotic membrane according to the Bulgarian and European law is a transplant, and therefore small hospitals are not having ability to do it just because they cannot fulfill the requirements. So those patients that we examined were put together into a prospective and retrospective study, and you see that we used a variety of different technology to see how amniotic membrane worked. And one of my followers, Associate Professor Yana Manova, did her PhD a couple of years ago based on this. So I'm going to share with you those exciting results because I believe that they're really exciting. In our practice, we used amniotic membrane from age 1 to age 95, so pretty much we can cover any age. And interesting thing is that we use it for a variety of different things. Like, for example, we use it for neurotrophic problems, we use it for recurrent erosions, very big chunk for trauma and burns, and also for infections. And those infections can be not only bacterial, they can be also viral, and we have very good results in hepatic keratitis, especially in hepatic keratitis with neurotrophic problems. So all those applications were used one or many times. And you can see here that approximately 60% of our cases were single amniotic membrane transplantation. So in 60%, the effect was after one transplantation, which is really unique. In some patients we did 2, 3, and in some patients we did even up to 10 transplantations, but finally we achieved either good visual and comfort or just good comfort result. And those are the results relating to the comfort. Pain, redness, and tearing are reducing significantly after amniotic membrane transplantation, and those results are statistically significant, and this actually shows that this is a very good tool. And I think that amniotic membrane is not only a tool to manage anterior ocular surface, but this is a very good scaffold, and we are working currently on that. And microstructural alteration is definitely improving, and you can see here an ulcer that is healing over time with OCT technology. So our conclusion on the basis of our 12 to 13 years experience with amniotic membrane in Bulgaria is that it's a very good option for managing anterior ocular surface problem. And basically we are trying to expand the application, and we are trying to expand the indications for application of the amniotic membrane. We actually made a step further, because as you can see at the beginning, we took the membrane from a tissue bank. After that, another agency called Bioregeneration made their product, and 2 years ago we decided to make our own product. So now we have AWAM, which is a product produced by Santa Marina Hospital, which is the hospital of the Medical University Varna. And this amniotic membrane is put in a special media, which is the MEM media. And you see here that it has a pink color. And as far as we have some changes, like pH changes or temperature changes, the media changes its color to purple. So immediately we are able to see that there is some problem. The membrane is prepared, as you can see, exclusively in the translation laboratory, and we have a very strict protocol for it, and this is part of the laboratory, and the advantage is that this laboratory is really up to date and very well equipped. And this is my former Associate Professor Jana Manova when she was doing her PhD defense open public, and she was talking a lot about amniotic membrane. When it comes to amniotic membrane, I cannot abstain of talking a little bit of so-called pack cross-linking. Pack cross-linking is a unique concept. In Africa, they were using riboflavin for ages in order to sterilize water, in order to free it from microorganisms. Of course, it cannot be absolutely sterile, but it's just a way of disinfection and decreasing the microbe counting of the water. And this can be used in clinical practice. This is a unique concept, and we are having quite a lot of good results out of it. What we did, which is different than the practice in the world, is we did pack cross-linking together with amniotic membrane transplantation. And we actually reporting here 11 eyes which are improving their visual acuity even within 3 months to more than 0.3. So we believe that if we combine contemporary technologies, like in this case pack cross-linking with amniotic membrane, we can have much better results. So as you can see here, this eye is with amniotic membrane and contact lens. It's not infected anymore, and this eye is one of the eyes that achieved visual acuity of 0.3 at the end of the day. In future, I know that there is something which is called CI, and people are working on the idea that this thing is just an attachment to the slit lamp, and pack cross-linking is provided as a standard eye care for the entire Africa. And maybe we will be able to do a dry alarm which can be combined in this case and help those patients. So my conclusion is that pack cross-linking is effective, but we have a variety of different options there, and by combining them we may achieve better results. And finally, I would like to concentrate on my seventh wonder. This is my final wonder, and this is the UV effect on the ocular surface. Many years ago, I met Minas Coronel, who is having this camera designed. And this camera has the idea that with autofluorescence, we see the changes that with clinical examination we cannot see, and those are probably caused by the UV light. But we are not absolutely sure, because those autofluorescent events we see, for example, after corneal graft transplantation. We see them in pterygium, but we see them after surgery as well. So it is quite interesting to understand what it is. And we managed to find a way to design a somehow better camera, because we managed to use better objective lens. Of course, Coronel camera was designed many years ago, and today we have better bodies of Nikon. The most important thing, however, when we are looking for this, is that we have a free of UV filter matrix, and this is the really challenging part of designing such UV camera. Also, we need to have special flashes, and those flashes should have filters which are coupling with the filters that we put in front of the camera and objective lens in order to have better quality pictures. And we actually did, and as I already mentioned, those are some of our pictures. You can see those autofluorescence not only with pathology like pterygium, but also you can see it after surgery, and the lower example here is exactly after surgery. So the idea is how we can prove what exactly we see after autofluorescent picture, because autofluorescence is probably a very good screening tool, but we need to know what exactly is happening inside. And of course, confocal microscopy is a very, very useful tool for this purpose. And we set up an investigator-driven prospective study, which included population study, acute burn study, and solarium study. And I'm going to show you some of the results here. Those are the so-called UV studies in Bulgaria. And the first part was a population study. We just used Facebook and some of our students that would stay at the Black Sea level for the whole summer. We examined them before and after the summer period. And those black cysts were the main observation after the summer period. So those lesions really increased significantly for the entire population after the summer period. Of course, we don't know what they are because they may be just simple cysts, they may be some degenerative changes. What is this black thing inside? Is it empty cyst or it's some other problem? But the results are showing that for all areas, superior, inferior, nasal and temporal, we always have increase of the cysts by number and size after the summer period. And this is just a summary of what we observed. This is a paper that is already accepted for publication and it's going to be probably online within a few months. But those are the total results. The total area of the cyst was significantly higher. And we do believe that this has an effect on the aging of the anterior ocular surface. We do believe that it has a cumulative effect. Of course, we cannot prove it because our students are not staying at the same place for so long period of time, but we had a very small group of students that we followed over 2 years, and we discovered that every year they have more and more changes after the summer period. Then we came to this fantastic idea. Okay, summer exposure is very, very variable. We have no idea how long this patient spends outside or this subject spends outside. Do they wear glasses? Do they wear a hat? Do they have habit to go under the shadow or they like to expose themselves? But people that would like to have solarium treatment and really suffer this disease called anorexia, they really have some control on the amount of energy that goes into their eyes. Anorexia, I said, is a disease. It's somehow dependency because after UV exposure you have increased level of endorphins. That's why people that are used to having tan, they have some eagerness to have it again and again, just because that makes them not only look better in their eyes but also feel better. So we managed to recruit 50 subjects. Those were girls that really use voluntarily the solarium. And interestingly, some of them were using protective goggles. However, some of them did not use protective goggles. They would prefer just to close their eyes, as shown on this picture, or they were using a flannel towel to cover the whole face. And we managed to look what exactly is going on, again utilizing confocal microscopy. And this is what our results are. Every subject who was having tanorexic behavior, so they were going regularly to solarium, they were having those microcysts in their conjunctiva. But they were small and small as number and as size as well. 2 weeks after the solarium, the number of cysts was enormous, and the bigger and more cysts we observed in patients that were not using their protective goggles because they would not like to have those marks around their eyes. And in some patients we managed to put a protective contact lens, and in those patients we were still seeing some conjunctival changes, but they were significantly less in number than in unprotected patients. So those cysts definitely are associated with UV exposure. At the moment, we are absolutely convinced that they have transient nature. However, what is their long-term effect on the ocular surface? Of course, we can speculate that this can be a reason for dry eye, for marginal vascularization, for meibomian gland disease, for chronic dry eye, and more and more and more. We still need to look at all those factors, and because this is a multifactorial disease, and of course because of the environmental implementation of the UV and its effect on the anterior ocular surface, everything looks very complicated. But I do believe that in the future we will need more and more attention to the UV protection of the anterior ocular surface. So wonderful. In ophthalmology, we have 7 wonders, at least in my ophthalmology. But I also was thinking about the trio perspective. Trio perspective meaning that eye care practitioners, like medical opticians, optometrists, and eye doctors, ophthalmologists, are working together. In Bulgaria, that was not looking very promising about 15 years ago. And I started gradually to try to introduce this concept. And in 2012, at the Medical University of Varna, we managed to introduce a new specialty called medical optician. And those are our first graduates from medical optician. The class has graduated 2016, and the idea was that those people would have an accent on the eye health, not only on optics. They will have basic medical knowledge. They will have integrated approach to the eye problems. They will be patent to work in the clinical practice, do lots of evaluations, for example, OCT, visual field analysis, and so on, and they can integrate into the eye care. But of course, that is not enough. This is again the first class, and I wanted to make a step forward. And optometry was always something which I was going for. And in 2016, when those people finished their bachelor's degree, we managed to organize for them a new medical specialty, which is specialty in optometry. They are going to graduate in this autumn. That will be the first class of medical optometry in Bulgaria, 2018. And our optometrists should be the ambassadors of eye health. They should have integrated approach to the eye care problems. They should have basic ophthalmological knowledge. They will not prescribe because they will not have rights to prescribe, but they will be able to independently diagnose eye health. And this is, for example, one of the girls. She was wondering what is doing a minus lens. And now she is absolutely patent to examine patients, to prescribe glasses, and even to apply dilating drops. And first success is actually on this picture. This is one of our graduates who this year participated in international contest called Force, organized by Cupovision, and he was acknowledged for his presentation skills. So the care of the eye is very complex. It contains refraction, optical correction. It is clinical and therapeutic specialty as well, but it's a surgical specialty. We have cosmesis and we do blepharoplasties as well. And it's a high-tech specialty, as you can see on this picture. One final thing. For me, vision is the most important human sense. And because it is the most important human sense, I'm very proud that I dedicated all those years. And I'm very proud that I really enjoyed examining the eye. Like Jay Kretschmer says, it was my privilege. I would like to also acknowledge several people, not only several, quite a few, and those are my teachers from my very young age, and of course my mentors and people that are currently people that I'm working with, and my current boss, Professor Krasimir Ivanov, who is director of the university. And with all those people, I'm working every day, or I have worked for a short period of time, but they made a significant impact on my development. I would like to thank my students and followers, because those people really make me feel good, because that means that I'm doing something right. And those people are constantly behind me, and they really help me to push lots of projects in ophthalmology. Of course, I would like to thank my friends and my family, and especially I would like to thank my son, because without him I could not make it through. And those are some members of my family, my grandmother, my grandfather, my late husband, and lots of friends from my school, and of course my son. And I would like to thank everyone who in one way or another influenced my development, because without people around myself, I could not make it till today. And I would be happy also to thank all the people that all the time are absolutely invisible, because they are doing lots of technical work. For example, nurses in the theater, assistants at different levels, at different positions, and other colleagues that are referring patients, that are managing patients behind the scenes, and everybody who actually is working with me in one way or another. Finally, I would like to thank my institution, and I would like to conclude that I hope that somehow I managed to lead an interest to ophthalmology with this talk. And I still believe that 50 is not an age that you should look not happy. And as you can see from this picture, I'm looking happy, and I'm looking forward for the next 50 years. Thank you very much, and please be my guest and look at this lecture, and if you have any questions, you always can email me, because all of you are having my email. Cheers.